So there are nothing to be disclosed. So today I'd like to present overview of fluorescence guide surgery for hepatoblastoma. As you know, Icg is a popular diagnostic reagent for the liver function test, as well as a measurement of the cardiac output and retinal angiography. When the Icg protein copy is excited by a light source with a wavelength between 750 and 810 nanometer, fluorescent light with a wavelength around 830 nanometer is emitted. The human eye cannot see these wavelengths. So once Icg is injected intravenously, Icg uptake into liver cells and metastatic liver cell, hepatic tumors. Then Icg wash out into bile duct immediately. So therefore Icg is detectable in tumor cell only by infrared ray after more than 24 hours after injection. Like this. So for Icg navigation surgery for hepatoblastoma, when should we inject before surgery? We usually inject Icg 1 day before surgery for metastastectomy. For laparoscopy, we usually actually inject more than 3 days before surgery because Icg fluorescence from bile duct remain in the intestine in the case who underwent Icg injection 1 day before surgery. There are available Icg detectors. Broadly speaking, there are two types of detectors: handheld cameras and endoscopic type, like this. So this PD system is customized for detection of Icg fluorescence. These regions were difficult to be identified by eye. Microscopically, these were consequently identified as micrometastases. Then, these regions were identified by this navigation system. So this is a representative case. CT scan shows the existing of lung metastasis. You can see several fluorescence positive nodules. They are metastases in lung lobe, and these are metastases in lymph node. There are representative small nodules which were suspected as lung metastases. In these cases, here and here and here, we have tried Icg navigation surgery. So this is a 5 millimeter diameter metastasis. This tumor was difficult to be identified by eye, but Icg positive nodule was nicely navigated here. This is a less than 1 millimeter diameter metastasis here. This could not be identified by by eye, but Icg positive nodule was nicely navigated here. There are examples for micrometastasis under navigation surgery we experienced. These lesions were difficult to be identified by naked eye. The nodule less than 0.1 millimeter were detectable by Icg navigation. In this case, pulmonary metastasis almost diminished by chemotherapy. Before liver transplantation, we performed exploratory thoracotomy using Icg navigation. Here, we detected slightly positive lesion here. So the hematoxin aging staining of the detected specimen are shown in this slide. This is a suspected existence of the tumor cell. Using the fluorescence microscope for Icg detection, we can identify Icg positive signal in this regional tumor cell. Icg Navigation is also available in birds. In thoracoscopic surgery, we can detect the Icg positive region, and we reject this region like this. So this is rejected tissues. This is Icg positive. At present, we are now experiencing more than 100 operations in 41 cases. Consequently, 323 lung regions rejected. And among them, 295 were fluorescence positive and 244 involved viable tumor cells. Sensitivity is approximately 80%. On the other hand, 25 or 28 Icg negative nodules were not malignant. Specificity also the 80%. Histologically, upper case were lung metastasis. You can see this nodule contained Icg positive scales. On the other hand, lower was a false positive nodule. There were inflammatory cells exist here. This is such as a macrophage or lymphocyte. Some inflammatory cells might somehow show slightly positive signal, like this. This case was pretext-free with lung metastasis. After cycle 4 induction therapy, lung metastases were diminished, and primary tumor was downstaging as post-X2. Then we rejected this tumor. This is a she-navigated left hepatotomy. You can see the fluorescence positive tumor here. This tumor located at the middle hepatic vein. We rejected this tumor along middle hepatic vein here. After rejection, Icg remain on the cutoff surface here. So we performed additional rejection at the fluorescent positive region like this. After additional rejection, Icg was gone here. So this case was underwent liver transplantation 4 years ago, have a peritoneal recurrence and multiple metastases in transplanted liver. You can see the nicely Icg positive nodule here. And there are small Icg positive nodule here existed in this row in the transplanted liver. So this is exploitated liver specimen. As you can see, there are multiple metastases in this transplanted liver. This shows the metastasis of peritoneal region, Icg positive region here, the metastatic region. And this case has a metastatic omentum. You can see the metastasis nodule in this omentum. We tried Icg navigation surgery in 21 primary tumor resection. All primary tumor was positive. Among them, 11 were multifocal, and one showed diaphragmatic invasion for positive margin. But among them, 3 were false positive due to remaining of bile. Moreover, we detected metastasis in 6 operations as shown in this below of this slide. In this case, this tumor was undetected by Icg. By the pushing to lung like this, you can see the like this. You can see the Icg signals. Icg navigation has a limitation of deep region. This is a rejected tissue. You can see the Icg positive metastatic lesion. This is a case who underwent segment tectomy for small nodule segmental 8D. In laparoscopy, we punctured portal vein in segment 8D under echo guiding like this. Then laparoscopic was changed to Icg detecting more. Like this. This is a Icg positive lesion 3 days before injected Icg. As you can see, Icg fluorescence was exposed to view like this. Here. This is the metastatic region. You can see the segmental 8D segment here. And the same 8D was nicely dining by Icg, and we eject this region under laparoscopy, like this. So in the shining green, fluorescence navigation imaging surgery achieved precise and sensitive detection of metastasis as well as primary tumor in hepatoblastoma, especially for small and multifocal region, except hepatic invasion and lymph node metastasis. So they are collaborators. Thank you for your attention.